Infrared light, an important therapy you likely don't know enough about. Hi, this is Dr. Mercola helping you take control of your health, and today we are joined by Dr. Michael Hamblin.
So you started off introducing a concept you called infrared therapy, and that is part of a thing that we call photobiomodulations. So that starts about 750 nanometers and goes all the way into maybe 1200 nanometers. That's the near infrared, which has a lot of biological effects, and it also penetrates well into the body. Because other colors of light, like blue and green, have a lot of biological effects, but they don't penetrate too well. So ideally, we want to have highly active wavelengths of light that penetrate well into the body.
With respect to the penetration, it's my understanding that those higher wavelengths beyond 900 to 1,000 nanometers tend not to penetrate well. They do penetrate, but the problem is that the water, which is a magnificent chromophore, absorbs them before they get to the tissues.
The accepted mechanism in the mitochondria involves dissociation of nitric oxide from cytochrome C oxidase, increasing electron transport and ATP synthesis. But, you know, by and large, the thing to remember about photobiomodulation is it's highly biphasic in dose. So many people have got themselves into trouble by giving too much light.
I definitely want to touch on that. So please expand, because this is a massively important concept. It's the Goldilocks dose. There's this narrow range where it's going to give you benefit, and if below that, not much benefit, and above, you can actually cause harm.
Well, that's the idea, yes. I mean, it's not a narrow range, actually. It's quite a wide range. So, you know, obviously there's a power density, what we call milliwatts per square centimeter. There is a level where nothing will happen. You can sit in this light 24 hours a day, it'll have no effect, right? But that's very low levels of light. So then you raise the dose and you get biological effects. And if you keep raising it, these effects will diminish. And it's possible that if you give a huge amount of light, you could actually damage the tissue. I think the thing about LEDs is that generally you put them right next to your skin, and for a relatively brief period, 10 minutes, 20 minutes, that sort of period, and you can feel the benefit. I don't know if you've seen, but there's a whole body light bed. James Carroll Thor makes this, called the Novo Thor. And it's an amazing thing. It's 500 watts of LED power, and you can climb in it for like 10 minutes, and you can feel the difference. I mean, you really can.
Well, let me ask you a sort of a tweaking question, because it seems we never really addressed the wavelength the optimized wavelength for stimulating cytochrome C oxidase. There seems to be a range of about 810 to 830, and you just mentioned 850. What would your guess be for in your studies show that is the ideal target? Because these and when you answer that, we'll talk about some other components too, because I think that is a very narrow focus stream, and I want to compare that to the analog exposure that you get from something like sunlight.
Yeah. So, you know, we've done a lot of studies over the years, and we cannot really detect a difference between red light like 660 and near infrared, let us say 810, 830, 850. So first of all the 800s seem to be the same, and also, as far as we can tell, something in the mid 600s like 660 is the same as the near infrared. Now, I think a few other folks have claimed to find some differences, but there's not much difference.
Really? So the red at 660 will still provide the same mitochondrial benefits?
Yep, absolutely.
I did not know that. That is interesting. I didn't I thought they were completely different, but it makes sense because they're pretty close. I mean, they're not that far apart.
No, but in between, 730 does virtually nothing.
Interesting. Why do you think that is?
Well, the theory is the absorption spectrum of cytochrome C oxidase has two peaks, one in the mid 600s and one about 800.
Okay.
And Tina Carew published that, and the Wisconsin folks published that. Several folks have done that. Obviously, one of the big growth areas is the brain. And this is really intriguing because folks find benefits in the brain by putting all sorts of light on the head. High power near infrared lasers and high power LEDs, but relatively low power devices that can go up the nose, they can go in the ears, they can go different parts of the head. And everybody thinks, well, the photons have got to get in the brain, so there's got to be a certain power density. But it's not clear. I mean, the photons can be absorbed in the blood. You have blood circulating in your scalp. You have bone marrow in the bone of your skull, and it's known that light is very good at activating stem cells in bone marrow. That's one of the big deals. Clearly that photobiomodulation has huge effects on the brain. Still, the jury's out. What is the best way to get the light in your head?
Especially with respect to treating neurodegenerative diseases like Alzheimer's.
Absolutely.
So maybe you could summarize what you've learned to date.
Yeah. So, there's only been a few studies so far about photobiomodulation for Alzheimer's. And since Alzheimer's is going to be the huge epidemic and it's going to decimate healthcare costs and all this, the fact that most drug trials for Alzheimer's have failed dismally, right? I mean, at the cost of billions of dollars, and like a few folks with small trials for Alzheimer's get results so good that nobody can believe them. These are people, old folks who can never set a coherent sentence in weeks and months, suddenly kind of start talking with their relatives. And people who had to be fed suddenly start using a knife and fork. I mean, a lot of people just can't believe it. And, we do have some statistics that only relatively small series of patients, but we do have statistical significance. And in my opinion, the effects are so surprisingly good that this has to spread. I mean, it really has to spread. People have to do big trials, and I would expect in 5 or 10 years that photobiomodulation for Alzheimer's has to be pretty much out there.
I'm wondering if we could go back and really address the Goldilocks dose, because you mentioned that there's a fairly significant band of therapeutic efficacy, but at some point it becomes actually counterproductive and actually causes more harm than good. So what do you think the window is with respect to the number of watts of these LEDs that you'd be putting on your scalp?
Right. I mean, again, this is a good question. Is it the total amount of energy you're putting in your body? Because these arrays, and for instance, the whole body light bed is a huge area, right? The power density is modest. It's the same as anybody would use 10 or 20 milliwatts per square centimeter.
Oh, that is the power density on that bed. Okay.
Yeah, but it's a big area. In fact, on the LED array, it's 10 or 20. So a lot of these devices have the same power density, but because they're big and there's a lot of diodes, you put more energy into the body. Now, what we don't really know is, can you overdose the body on total joules, or is it when it's concentrated? That's what we don't know. My gut feeling is that people are not going to stay under these things forever. So 10 minutes or half an hour, there's no harm at all.
Okay.
Maybe if you went to sleep all night, you would overdose yourself. It wouldn't surprise me, but mostly I tell people they can use these things for 10 or 20 minutes a day, and it'll have major benefits, and they're extremely likely to have any ill effects. A lot of people have problems with the brain, but other people have like orthopedic problems, musculoskeletal problems, where typically near-infrared photobiomodulation works great. The question just is, what's the best way to deliver it to the body?
Yes, indeed.
I think that for a lot of applications that are going to be great, nobody's really studied them much. And I'll give you one example, which is kidney failure, right? So kidney failure is the third leading cause of death. and these are old folks who are dying from kidney failure. You can't really give them transplants because they're elderly. And, you know, you put a near-infrared LED array around where their kidneys are, and this seems to work like a dream, but hardly being studied at all.
Any other exciting applications that you've seen it used for?
Well,
I wasn't aware of the kidney one.
Yeah, well, you know, diabetes, metabolic syndrome, diabetes, and again, you know, where do you put the light? I think most people end up putting it on the belly, right? Because, you know, light has effects on fats, and you know, it can melt it away a little bit, but it's anti-inflammatory, and a lot of these problems are caused by having excess inflammation in your sort of belly fat. Right? It's just like a big sort of reservoir of all these inflammatory cytokines. So I think,
could you explain the impact of near-infrared on the inflammatory process and the
well,
cytokines?
it's highly anti-inflammatory. It seems to change the macrophage phenotype from M1, which is pro-inflammatory and, you know, interleukin-1, TNF-alpha, IL-6, to M2 phenotype, which is IL-4, IL-10, TGF-beta. And the interesting thing is that M2 macrophages are really good at phagocytosis, right? So they gobble up the garbage. So in your brain, when you've got amyloid plaques or tau tangles or alpha-synuclein sort of aggregates, reducing the inflammation is key, but also encouraging the microglia to be good garbage removal agents, in my opinion, is hugely important. But nevertheless, for many systemic inflammatory disorders such as type 2 diabetes and metabolic syndrome and all these things, changing the inflammatory profile from pro-inflammatory to anti-inflammatory has a huge big deal. I mean, there's a startup company called LumaMe, which Clark Tedford started up, which is treating age-related macular degeneration with photobiomodulation. So there's a specific device, a bit like a slit lamp, and you put your eyes in the right sort of slots, and this machine shines light into your eyes, red and near infrared principally. And he's done clinical trials, and I don't know whether they're published yet, but you know, the odds are that it's highly effective, and he will eventually get FDA approval, and he'll be able to market this device to ophthalmologists, you know, a clinical device for ophthalmologists. And you know, so athletes get huge benefits from putting red near-infrared light on their muscles. A lot of them use LED arrays, some use whole body light beds. It's a huge big deal.
And what would the intention be for the muscles that they've just exercised or that they're using most actively? It's not going to improve endurance. It would just be muscle recovery, I would imagine, right?
Well, I mean, endurance to some degree. I mean, the time to exhaustion is extended with light therapy. So there's basically two ways athletes use this. One is preconditioning before your sports event. Then there's after, which helps recovery and delayed onset muscle soreness and all these things. But you know, if you combine light therapy with a training regimen, so each day you do your training, you get the light, and you go on like that, you can train a lot more effectively. I think this is going to really spread.
Well, it's exciting. As I said at the beginning of our interview, I'm really enamored with it because it's so inexpensive and so safe and so natural. I mean, LEDs aren't typically natural, but they're replicating a natural source, which is the sunlight switcher, which we've had since our ancestors first existed, whenever that was. So it seems optimizing that exposure would be a simple strategy that can, you know, improve your biology with relatively little to no risk.
No, quite agree.
Yeah, so it's great, and I am just so delighted that there are committed individuals like you, literally spent decades in the lab trying to figure this thing out, and and help us understand how we could practically use this. One of the intentions of my first starting this site was to radically decrease the time at which researchers like yourself, who've committed decades of their life's work to developing these principles, is to decrease the time at which it's clinically applied. Because normally, in the past, as you know, when you first started out, it could be half a century before this knowledge became common. So now we can decrease that time. So thank you so much.
Yeah, we're just coming up pretty much to the 50th anniversary. So, you know, Andre Mester was the first one to start treating non-healing wounds in 1967. So exactly.
And he did that with lasers, didn't he?
He did it with the ruby laser and then a Hemi laser. And for 20 years, everybody used lasers. But now LEDs are rapidly taking over.